Hi, my name is Jim Pfaus. I'm a professor of psychology and neuroscience in the Center for Studies in Behavioral Neurobiology in the Psychology Department at Concordia University in Montreal. And I'm going to be talking today about a hands-on approach to create therapies that hold promise in the management of hypoactive sexual desire disorder, or HSDD. Just some acknowledgments. So the goals for today's lecture, I would like to have an understanding of the behavioral, endocrine, and neurochemical systems that activate sexual desire and sexual inhibition. This is to help you understand the way that neurochemical systems are activated by hormones and then come online to activate the ability of an individual to see sexual cues in the environment and recognize them as such. I'd also like you to understand how these systems are altered in HSDD and why that alteration is sometimes very pervasive and difficult to overcome. Finally, I'd like to set up kind of logical targets for treatment, not simply serendipitous targets that, oh, this drug worked and we should go after this, but logical targets that's based on our understanding of how these systems work. So let's get right into it. Now, the sexual response cycle of humans was first kind of given by Albert Moll in 1908, but it was adapted by Maston and Johnson in 1966 as their EPOR model. The E stands for excitement, the P for plateau, the O for orgasm, and the R for resolution. The idea here is that sexual behavior has a beginning, a middle, and an end. And the beginning comes with excitement. That excitement is both driven, if you look down at the bottom, by desire and by arousal. So you can see that desire and arousal are in a relationship with one another. In fact, that relationship is reciprocal, where arousal can increase desire, desire can increase arousal. But once this happens from the standpoint of your autonomic nervous system, you start to have sex. Blood is engorged in the genitals, and instead of the sympathetic system being activated, now the parasympathetic comes online to maintain that blood there. That's the plateau phase, where you're maintaining blood in the genitals. When you reach orgasm, however, that orgasm induces, or it both induces and is induced by activation of the sympathetic nervous system, which then allows blood during the refractory period to flow back out of the genitals and back into the core. You can see in women there are a number of different kinds of orgasmic styles that they may have. Men typically have a more unitary style, one or two, possibly more if they're lucky. But what this means is that you have the same kind of autonomic response. That's why it's called a sexual response cycle in humans. Now, you can see in women that the excitement is going to initially cause engorgement of the labia and the swelling of the clitoris. So the blood is flowing through the vagina into these tissues in order for that to happen. And the increasing red, as you can see here, is increasing blood flow to those regions where they become engorged. The engorgement is necessary both to increase the surface area of the clitoris to allow more stimulation to occur, but also to increase blood flow to the vagina to allow a tighter fit. Now, when orgasm happens, as a sympathetic response, blood vessels open up and the blood begins to flow back through the vagina into the core. And as you can see, back into the resting period or the refractory period, that blood flow has now left and the tissues stop engorging and detumesce. We can see this reflected not only in these physiological responses, but also in the faces of individuals who are experiencing them at the time. Orgasm can move from an excitement phase to a plateau phase to an orgasmic phase to a resting phase. And typically, the orgasmic phase, quite often, if you show pictures like this to people, they'll say, wow, she looks like she's in pain. But in fact, there's a very close relationship between pain and pleasure with regard to the sexual system. So people are responsive to it, and they respond to it. They know what's happening. They're consciously aware of it. We see that peak desire occurs in a normal response during ovulation. So if you look at the human menstrual cycle here on the upper left-hand side, you'll see that estradiol has peaked and is on its way down prior to ovulation. See the progesterone levels go up and then go up further during the luteal phase. Testosterone increasing its its secretion by the ovaries is consonant with the period of ovulation. So the day of ovulation and afterwards, like with estradiol, you have a peak of testosterone that happens on that day and the day after. And of course, if you look down to the human sexual desire, the number of women reporting sexual desire is at its peak during ovulation and the day after. So it's consonant with testosterone increases that have been preceded by estradiol. We can see this in the rat estrus cycle, so it's really a mammalian thing with testosterone peaking on the day of ovulation. And even in rhesus macaques, we can see that their approach toward males is peaking on the day before ovulation, but their actual solicitations of males in order to have sex is peaking on the day after. So there are rules, common rules, for how these systems work, driven by this hormonal milieu of estradiol and testosterone and subsequent progesterone. Let's have some definitions. What do we mean by sexual arousal and desire? Well, arousal itself is typically described as increased genital blood flow. It's got to be about the genitals if it's going to be sexual. But that's not the only thing that happens. You have an increase in heart rate, increase in sweating, increase in pupil dilation. Every kind of autonomic response that is indicative of sympathetic arousal occurs during sexual arousal. And that can occur without a woman's conscious awareness, especially when we're talking about increased genital blood flow. Sexual desire or interest, on the other hand, is a much more conscious awareness, a wanting or craving of sexual activity, behaviors that are aimed at acquiring sex partners like solicitations, or that are aimed at acquiring sexual reward because you don't need a partner to masturbate. So these could be behaviors, any behavior that's aimed at becoming sexual, at engaging in sexual response, and then producing a sexual reward. Now, what do we mean by sexual reward? Typically, that could mean pleasure or intimacy. It can mean the orgasm that you experience that is sexual pleasure, but it can also mean the pleasure that you have from bonding with your partner, from control that you might have, from other rewards that you experience, say, during a sexual arousal or during a period of sexual desire where you're going after a sex partner. When sex is concluded, however, sexual inhibition comes online. That inhibition is typically, with orgasm, reflected in something we call satiety. This is what you experience when you're finished. When you've had a big meal, you have satiety, you're done. And you know you're done after the number of orgasms that you would typically have that tell you you're done. And this involves brain mechanisms that are essentially dampening or putting inhibition on the mechanisms of arousal and desire. It can also be reflected, however, by primary aversion. If you're a woman with dyspareunia, for example, and so entry is painful, you're going to be averse to that. And having inhibition then is consonant with your ability to shut it off rather than turn it on. And you may also have inhibition as secondary avoidance of sexual activity. When we look at how this might work, Rosemary Basson has a model of desire which is reflected in these two types of desire. One is innate, which would be hormonally driven, like you would see during ovulation, and the other is responsive desire, which is much more experientially driven by your expectations of what your sexual reward actually is. We can think of innate sexual desire, hormonally driven, as something which increases your receptiveness to sexual stimuli, increases the arousal that you get in response to those stimuli, which then drives you on to responsive desire, which then makes you aware of rewards that are sexual and non-sexual, allows you to open up to numerous incentives for sex, different types that you find hot, different kinds of experiences that you find sexually arousing, which leads to increased sexual receptiveness, more sexual stimuli, more sexual arousal. And so you can imagine that this whole circular model is a positive feedback system. Of course, it can be a negative feedback system. You may have innate sexual desire, but your experience of desire doesn't lead to reward. And when that happens, this, by Xing this out, decreases the incentives for sex. It decreases sexual responsiveness, decreases the number of sexual stimuli that you regard as hot, and hence diminishes sexual arousal. So you can see the circular model going both ways, to increase or to decrease. And this gets reflected then in typical dichotomous or dual control models, where you would have excitation on one side of a sexual tipping point, inhibition on the other side of a sexual tipping point. And this, of course, can weigh down toward excitation if, for example, the physiological and organic issues that are weighing you toward that are operating. And that, of course, has also psychosocial, cultural, and behavioral issues that are saying, yes, this is the right time, this is the right place, this is the right person, that are now weighing you down into excitation and into sexual activity. With HSDD, we find that the physiological and organic issues are weighing you down toward inhibition. This can either be because you have too much inhibition present in the brain, or because the psychosocial, cultural, and behavioral issues and your experience with sexual responding have driven you into inhibition, into feeling ashamed, into feeling guilty, into feeling like this is not the right thing that I am doing at the time. And when this weighs you down toward inhibition, it means that the excitation has to either be much greater in order to tip it the other way around this tipping point, or you're simply stuck in an inhibited state. When we can tear the processes apart and separate them, you can imagine that the hormones, and this would of course be the innate desire, the circulating levels in the brain, are activating arousability and attention. The activation of arousability comes with norepinephrine and oxytocin, where you're actually kind of coordinating the activity in your brain and in your periphery to give you arousal. The attention toward those cues that are arousing in the environment comes from dopamine and melanocortins, as you can see underneath. So here we have norepinephrine and oxytocin activating arousability. Here we have central dopamine and melanocortins activating attention. And of course, as you increase the sensory input from the genitals, which is your perception of arousal, and combine that with the sensory input from the incentives, which could be olfactory, visual, auditory, whatever they might be, this is now going to lead to net behavioral output. So your interest in sex, your solicitation of sex, your pursuit of sex, the actual copulation that you achieve. Of course, all of this can be done from experience and expectation. So here's the other side, your responsive desire, which is also activating arousability through the same mechanisms and activating attention through the same mechanisms, which are then going to combine with these internal and external incentives to produce your net behavioral output. All of that gets inhibited with reward and satiety, with the refractory period, which is activating opioids at the point of orgasm, serotonin, which gets activated to produce satiety, and endocannabinoids, which are producing a kind of sedative-like state that you have when you're cuddling, for example, after sex. All of that can also be activated by stress or aversion. So you can imagine that this would be, in the response cycle, the reward of satiety is in the end point, the aftermath of the orgasm. But if that doesn't get achieved, and if sex is stressful, if you've had bad experiences, stress or aversion comes online to activate exactly the same systems. So how does this work, and how do we know? One thing to consider is that what you want for sexual excitation is to tip the balance toward the activation of dopamine, norepinephrine, oxytocin, and melanocortins. There are drugs that do this, but there are states that do that. Feeling that sexual excitation that Masters and Johnson talk about, having desire, all of these will activate this system and weigh you down toward excitation. Of course, drugs or states that inhibit the systems that would come online during inhibition or refractoriness will do the same thing. So sexual excitation is going to depend on how labile this critical area here, which is the tipping point, actually is. How well is that tipping point able to move to the excitation or be held in check by inhibition? One of the major systems that is excitatory in the brain is dopamine. And dopamine, of course, comes from these brainstem areas like the ventral tegmental area here, the substantia nigra, and they feed forward to the forebrain and to areas around the emotional parts of the brain, like the nucleus accumbens, which give you motivation and desire and reward. Endocrine and autonomic regulation come in these more hypothalamic systems, like the medial preoptic area, which help to take the motivation and coordinate it with blood flow into the rest of the body. These systems are absolutely critical for attention and movement and coordinated endocrine responses and blood flow responses to prepare your body for sex. Of course, you can't happen without noradrenaline, which produces arousal, general arousal. These cell bodies are in the locus coeruleus here in the brainstem, and they feed forward to the same areas of the brain and to the cortex, which are involved in central arousal. So when you have central arousal and you have focused attention, this is the activation of dopamine and noradrenaline. Within dopamine systems, the idea is simple. Sensory input is activating the medial preoptic area, the mesolimbic dopamine system, and the nigrostriatal system. This mPOA is coordinating genital responses with the appetitive behaviors, the desire-related behaviors that you're engaging in, and those behaviors have to have coordinated somatomotor patterns. The mesolimbic system is largely driving these appetitive behaviors, the nigrostriatal largely driving the somatomotor, all of which is under the coordination of this hypothalamic medial preoptic area. Here's the medial preoptic area, very small little area in the hypothalamus here. It's around the third ventricle, underneath this fiber pathway that connects both sides of the brain, and it's a very small region right here. That region contains probably about 10,000 neurons, which are not only projecting to the rest of the brain, but also projecting down into the brain stem, coordinating the spinal activation of autonomic arousal. You can see here that the medial preoptic area in men and women who are responding to visual erotica is activated. The red, of course, is increased blood flow or increased bold activation. So you can see it in men and women who are watching visual erotica. So it's a normal response that you would get to have this now saying, oh, I am about to be horny. I am now going to coordinate my blood flow with my attention. And as a neural excitatory system, this medial preoptic area is literally in the center of the systems that I've described to you. It is going to be activating blood flow through its outputs going down to the brainstem. It's also going to be activating mesolimbic dopamine here in the ventral tegmental area. So you're activating dopamine in the medial preoptic area. Its outputs are going down to the ventral tegmental area to activate that mesolimbic dopamine system, which is now going to essentially take over the emotional systems in the limbic structures of your brain and go up to the prefrontal cortex here, essentially to shut down all the inhibition that comes from the prefrontal. This is your turn-off center. This is the center that shows executive function, that basically tells movements to stop when other movements need to go. You need this system to be coordinated, but when the system is activated too much, it will shut everything down. So instead of having this system turned on, the activation of this mesolimbic dopamine comes up here to turn it off, to allow you to be in the moment, to allow you to be sexual and in the moment, and then allow the activation of all these limbic structures to come online to give you the pleasure and that wanton desire that you have during sexual interaction. Essentially, when we talk about the activation of tumescence and detumescence, the mPOA is important in this. Here's the hypothalamic mPOA activating a dopamine 1 receptor. That activation comes down and is driven by the tactile stimulation coming into the clitoris and the genitals. It's the same thing in men, activating that somatotactile sensory cortex, which then further activates the mPOA. When blood flow is either maintained in the genitals or maintained out of the genitals, you've shifted from D1 to D2. The D2 dopamine receptor is now keeping blood in the genitals, allowing this tactile stimulation to now produce the plateau phase. When this shifts back to D1, and that's the shift here to here, now you've activated orgasm, you've activated the sympathetic nervous system again, but to produce these post-orgasmic afferent inputs to the thalamus, to, in this case, the medial amygdala, which activates opioids that come online in the mPOA to shut everything down. So this is your normal sexual response cycle as it relates to genital tumescence and detumescence, which of course is your perception of sexual arousal. As we look at for other excitatory systems, we have systems that modulate dopamine. The one I'm going to talk about right now is the melanocortins, as you can see here. Melanocortins come from this hypothalamic arcuate nucleus, and they radiate out to all the same structures that dopamine system that I talked about earlier radiates out to. And as you can see, melanocortins have a long history of being associated with sexual behavior. These pro-opioid melanocortin peptides, which include adrenocorticotrophic hormone, or ACTH, and alpha-MSH, have pronounced effects on sexual behavior of female and male rats. The alpha-MSH facilitates lordosis, which is that arching of the back in estrogen-prime females, and it facilitates erection in males. And alpha-MSH levels in the anterior hypothalamus are increased by estrogen, suggesting that it may be one of several intermediaries of estrogen action. So again, on the day of ovulation, you have amplified things like the alpha-MSH system. Bremelanotide is a compound that is currently in clinical trials, in late phase 3 clinical trials. It has a structure that is very similar to alpha-MSH. And as a structure similar to alpha-MSH, it binds to melanocortin 3 and 4 receptors in the brain. These melanocortin 4 receptors are the ones that are involved in desire. It induces erections in men. It induces erections in women, that is, erect clitorises. It induces erections in men with mild to moderate erectile difficulty. It induces erections in rats in a very rapid way. And in red here, it facilitates solicitations selectively in female rats. Here you see the action of melanocortins in the preoptic area. And what they do, if you think of melanocortins here as alpha-MSH or this bremelanotide compound, by binding to these MC4 receptors, in a system which doesn't have that, you have a normal dopamine response, which would be decreased release of dopamine or a normative release of dopamine. But when you're binding to these D1 receptors and activating that D1 output, you now have an increased response. So more dopamine activates more D1 receptors, and those D1 receptors now are leading to output that is not only increasing desire, but increasing genital blood flow. In female rats, we saw that there was a selective increase with bremelanotide in solicitations, and that increase was dose-dependent. There was no effect on lordosis in either animals primed fully with estrogen or progesterone or estradiol alone. No effect on lordosis, no effect on their pacing behaviors, where they control the males. So it's a selective increase in solicitations. This occurred in females primed with estrogen alone or estrogen plus progesterone, which means that you're adding above the estradiol alone, because the estradiol state here, if you look at the control group, is a state of sexual inhibition. So you are increasing this above that. In women, bremelanotide has produced dose-dependent increases in sexual desire, these components of the female sexual function inventory, the FSFI, and it decreases the distress that's associated with having HSDD. So again, subjects with primary HSDD show a decrease in distress and an increase in desire. And this is with on-demand bremelanotide. So very much like our rats, which are showing an increase in desire, we're seeing in women a similar kind of increase. Now what about sexual inhibition? Well, again, as we noted before, anything that makes this non-labile, so this could be drugs or states that activate these neurochemical systems, or drugs or states that inhibit those that are associated with excitement, will now produce a longer-term inhibition. One of the things that is inhibitory is serotonin. And I'm mentioning serotonin. The opioids, of course, are producing that kind of pleasure, the rush of pleasure at orgasm. They also produce inhibition because of the feedback to the medial preoptic area. But that inhibition is short-lived. The satiety inhibition, which is coming from the frontal cortex, is much more the purvey of serotonin, and that's much longer acting. So we have serotonin cell bodies here that are in the brainstem and the raphe nuclei. These more dorsal parts project to the medial preoptic area, nucleus accumbens, prefrontal cortex. You also have prefrontal cortex being activated by serotonin, coming down and shutting down the nucleus accumbens and medial preoptic area. So one of the things about the prefrontal cortex among its executive functions and its purvey of executive functions, things like forethought, concentration, learning from experience, interpreting social cues, but the one that I want to point out here is behavioral inhibition. The idea that you can shut things down when it's either the appropriate time to do that, for example, during a refractory period, or when you are under a stressful circumstance, so either the anticipation of bad or painful sex, or even being in the woods with a bear coming through your tent. Those produce behavioral inhibition because they have to. And that behavioral inhibition, again, is the purvey of this area, this prefrontal cortex and executive function. Now, one of the things that happens is that executive function is regulated by serotonin. The inhibitory outflow from the prefrontal cortex, which you see here in red, which inhibits the mPOA, which inhibits motor areas, which inhibits the amygdala, that inhibition is absolutely critical to shut down all of these excitatory circuits. So when that happens, what is happening? Well, this is what's happening. If you look at the brains of women without HSDD and women with HSDD, what you see when they're looking at erotic visual cues in the healthy women is an activation of all of those structures that I just pointed out. In women with HSDD, there's no mPOA activation, there's no cortical activation, there's no amygdala activation. Instead, you see activation of regions like down here in the brainstem that are feeding forward that are largely serotonergic. So what about that? Well, you can also look at patterns of activation in the right and left side that are activated. So there's more activation in women without HSDD, less activation of women with HSDD. And for deactivation, you can see more deactivation of inhibitory areas in women without HSDD and less deactivation of inhibitory areas in women with HSDD. So how does the brain become that way? Well, one interesting thing that's happened with the understanding the mechanism of action of offlibanserin, which is another drug that is now out called Addyi, that is in for the treatment of HSDD, is that when you knock out serotonin release, which is one of the things that Addyi does by being an agonist at 5-HT1A autoreceptors, which you see here on the presynaptic terminals of serotonin neurons, by activating these, you're shutting down serotonin release. The other thing that you're doing with Addyi is binding to these 5-HT2A receptors here in red. And here you're an antagonist. So you're blocking serotonergic action at these 5-HT2A receptors while also blocking serotonin release after binding as an agonist to these 5-HT1A receptors. So essentially, in the PFC, by decreasing serotonin, you're actually increasing the action of dopamine and norepinephrine. In the nucleus accumbens, you're decreasing serotonin. In the mPOA, you're decreasing serotonin but increasing dopamine and norepinephrine. And the action of that reverses that kind of brain structuring and activational structure that we saw before, which then leads to increased sexual desire, decreased sexual distress, and a modest increase in having sexually satisfying events. Here we see the effect of offlibanserin in female rats, which over time, after 21 days of daily offlibanserin, in animals that were primed fully with estrogen and progesterone, we have also seen this in animals primed with estrogen alone, leads to an increase in solicitations, an increase in hops and darts, a decrease in female defensive responses, and in doing that, the male rats that they're with are giving them more sexual interaction, more intromissions. We see a similar kind of effect. Here, we note that offlibanserin is having an effect to decrease serotonin in the prefrontal cortex, to decrease serotonin in the nucleus accumbens, and to decrease serotonin in the medial preoptic area. This action then increases norepinephrine and dopamine in the medial prefrontal cortex, and to increase norepinephrine and dopamine in the medial preoptic area. Very, very important that this happens because now you are essentially taking this brain and moving it from chronic inhibition into a more labile excitatory mode. Here we see the effect of offlibanserin in humans. And you see that the FSFI scores at week 24, so it's a delayed effect, are increased. The desire scores are increased over placebo. And the distress scores have gone down over placebo. And why is that important? Because it looks exactly like bremelanotide. Where bremelanotide might be amping excitation, offlibanserin is diminishing inhibition. So for the brain to function sexually, you have an integration of excitation and inhibition, which I showed you before as the cartoon around that labile sexual tipping point. But most of that occurs here in the medial preoptic area. This is your tipping point. This is the controller. This is output to the ventral tegmental area, to dopamine, is activating dopamine in these limbic structures. Its output to the rest of the brain stem is now coordinating that activation with genital blood flow. This, of course, can be diminished by outputs from the prefrontal cortex, which then shut it down. So the idea is, can we get at increased excitation by amping dopamine here, and can we get an increased inhibition by knocking out serotonin here? And it would seem that the drug effects of both bremelanotide and offlibanserin are doing that. So again, to reiterate, you want to amp excitation, you need to have drugs or states, that is, states of your brain, normal states of your brain around ovulation or around the right partner, whatever it might be, that are activating these excitatory systems. It can also be, again, what the hormones are inducing around the day of ovulation. You also need drugs or states that inhibit these. Both this and this can activate excitation. In the case of a brain that is stuck in inhibition, it is because drugs or states have activated these systems. And when these are activated, you're now in a chronic inhibitory state. And what you need then is to inhibit this or amplify this in order to change this state of affairs back to this state of affairs. We have some take-home messages. First, sexual desire depends critically on the activation of neurochemical systems for sexual excitation by erotic cues such as dopamine, noradrenaline, melanocortins, oxytocin. These are set up by the actions of ovarian estradiol and testosterone. Number two, sexual inhibition is a normal function of satiety. You need it in order to do the next phase. But this is driven by brain opioid, serotonin, and endocannabinoid systems. Here's the critical point, number three. If sexual excitation is too weak or sexual inhibition is too strong, HSDD is likely to occur in response to appropriate and competent appetitive sexual cues. So the lack of desire is normal in response to incompetent sexual stimuli. However, it can also occur as a physiological effect of hypoactive excitation or hyperactive inhibition, or as a neural systems adaptation to a chronic lack of sexual pleasure. If we think of what women experience in normal relationships, quite often a chronic lack of sexual pleasure can occur, which is why people go into sex therapy. But if during sex therapy that maintenance occurs, that is, that sexual inhibition occurs despite the fact that the two partners are working very, very hard to overcome it, it would indicate that there may well be a physiological effect of too much inhibition, which we need to go after, or too little excitation that we need to go after. So what are our current treatment options? Well, the current treatment options we have are offlibanserin, because it's out and approved by the Food and Drug Administration. We also have mindfulness therapy, sensate focus therapy of Masters and Johnson. And if you think about how they work, really what's happening is they're trying to put you in the moment. And if you're not in the moment, it's because of behavioral and essentially cognitive inhibition. So what you need to do by getting in the moment, which is what mindfulness therapy does, is you need to basically shut down your overactive frontal lobe and say, yes, I know I need to take the kids to soccer tomorrow, but I'm in the moment with my partner. And in order to do that, you have to shut this down. That works in women who don't have an overabundant physiological serotonergic response. If they do have that, they may need the help of something like offlibanserin. It may be the case that other compounds, which are currently in clinical trials, which you see here in a brownish-orange color, like bupropion trazodone, which together are given as Lorexis, or testosterone and buspirone, which together are given as Liberdose, will do exactly the same thing, knocking down serotonin in the prefrontal and amping excitation in the hypothalamus and brainstem. We also have drugs in end-phase clinical trials like bremelanotide and the combination of testosterone and sildenafil, which is called Libido. These are likely amplifying this hypothalamic mPOA system, activating dopamine then to activate the outputs going both to the brainstem to activate blood flow and to these limbic structures to activate the desire components. Either way, if you have women with too little excitation, they may well need bremelanotide or Libido. Women with too much inhibition may well need flibanserin, Libidose, or Lorexis. Time will tell as these drugs become approved by the Food and Drug Administration and are used on demand elsewhere. But what is clear is that we have two different systems that can produce HSDD. One treated for the lack of excitation, one in treatment for too much inhibition.